Listen, medicine is a statistical medicine, is a statistical science. There's a certain percentage of people you will not, the best people can't touch. It does not. Some people, I'm not saying some people can't be touched at all. I can't touch them. It's absolutely, we all have failures. I've never seen a practitioner who has success with everyone. Doesn't exist. It just doesn't exist. Anybody who tells you that is lying. You know, I mean, actually I have a friend who claims he has that. But I think he's lying. I don't think he's consciously lying. I think, you know, well, okay, Miriam Lee. I used to work in Miriam Lee's clinic. And she would say, you know, and once a month on a Saturday we would have a class, and in the class she would go how, she would say, oh, this point, you know, she did master tongue. Miriam was very eclectic, she had all sorts, but she was famous for master tongue points. And she'd say, if you use this, and everyone, you know, whatever the problem it was supposed to fix, everyone gets better. I'm like, really? So then on a Monday I had to go, Miriam, you know, it's like, you say if you use this, everybody gets better. You know, what about this one? He never came back, and this one never came back, and you know, they didn't come back, they got better. I don't think so. They didn't come back because they didn't want your needles. It's like, because she was rough. And it was like, if they got better, they'll, I mean, at least one more treatment, they'll come back to make sure that it really stays. It's like, I think they didn't get any results. That's why they didn't come back. But in her mind, it's like, if they don't come back, they got better. So yeah, you can convince yourself that everybody got, I've never seen a practitioner who has 100% success rate. I think, and I talked to different people, and everybody has different ideas. So I talked about some, I won't name names, but someone who's relatively famous, and I know he's a successful practitioner. And I talked to people who assess this person in a clinic. And one person said, oh, he has 80% success rate. And another assistant said, he said, I don't think so. So I said, what do you think? He said 20% success rate. Yeah. Well, you know, so also success is a relative thing too. What did each one of these assistants see as a success, for example? Yeah, you know, I mean, was one of them judging first treatment only? You know, it's possible. I didn't get into the whole, you know, but I'm just saying that the highest I believe you can get is 80%. You know, it's like, we're human. If we could get more than 80%, I mean, even if we can get more than 60%, I think it's pretty cool. Okay? Because the reality is people get sick, and people don't always get better.
And now, are you talking about total resolution, or are you talking about...
Well, I don't know. Everyone according to their, you know, someday, I'm talking about patient satisfaction. You know, for some people, unless you fix the whole thing and they never see it, you know, nothing's ever there, it's useless. For some people, everything is cool if there's some improvement. It all depends on the patient and you, but I mean, and that's one of the things that we're responsible for in some ways, is to give people, in providing space in life, which is not really the subject of this, is that, you know, we're all going to get sick, we're all going to get old, we're all going to die. It's like, too bloody bad. But that's the reality, and if we're going to resist it constantly, you're going to be sick all the time, just mentally. So part of what we do sometimes, part of the resolution of a patient is the patient's coming to you not to resolve a symptom, but to resolve the capacity of embracing the symptoms. That's still a success, although medically speaking it's a total failure. So do I include it in the statistics? No, but I don't do statistics to begin with, even though I'm in a statistical science. It doesn't interest me enough. I'm not one of those people who go, this one yes, this one no, you know, it's like, you know, I don't do research. I only treat. And in treatment, it's very dependent on what the patient really wants. That's why some patients, that's one of the reasons, some patients are not going to get better with you. Because your agenda is going to be different than their agenda. You've got to accept that. Yes?
May I ask, so with the sort of general things like you're saying, diabetes or blood pressure or immune, it might be wise to treat those first before other things respond. So if someone has obviously high blood pressure, diabetes, but none of the protocol points work for any of their reflexes, you would
Yeah,
still
and there's
use
something,
them?
maybe, I mean, yeah, that it's, well, the question is there something else that works? No, I'm happy to abandon those protocols, but in all likelihood, someone who has diabetes protocol is going to do a good job for them. But if it doesn't, it's just another dogma, let it go, move on. Now, the other thing is, I'm saying that these tend to be primary, but maybe this person has something else that's more primary. By the way, no matter, things that you think are stupid and irrelevant can be the primary thing for that person. Somebody can have a vaccination scar, and that's the trick into their body. And until you fix that vaccination scar, and that's just an example. I mean, they can have a crooked toe, and until you did something to straighten that toe, nothing is, I mean, I remember, literally, I do remember a patient like that I had to really elongate the foot for them as I'm trying to work there, because if I let go, nothing was moving. And I didn't know what to do with needles to make that happen, So it's like you just never know what part of the fascia needs to be opened up, So these are just ideas, but, you find the right key into the right fascia, and that's all that matters. The rest is, all the other stuff, these are tools. It's like we were talking yesterday, these are rafts to get you across the river. Doesn't matter which raft you use. All that matters is you got to the other side of the river. So I'm suggesting that, yeah, diabetes, thyroid, autoimmune, are going to be efficient rafts if the person has the condition. But if you find if they're not working, don't keep rowing, because you're rowing against the stream. You've got to be smart about it. Make sense?
Yeah.
And well, we were talking about something and I totally spaced it out.
No, it was fine, you answered it well. It was.
Okay.
Can I?
But I answered it apparently. You see, this is patient success. The patient forgot they had a question. Yes.
So a lot of older people do have, pretty bad foot deformities and crossed toes and
Yes.
Do you put a lot of time into that in your investigation, or do you just go for,
I'm going to call it rheumatoid in all likelihood, and assume it's an autoimmune, or possibly, because if you have a deformity in one place, 2 places, 3 places, I'm okay calling it oral posture. If you have it all over, I'm sorry, that does not look like osteo to me. That to me looks like rheumatoid. Now, you can say that what I call rheumatoid is not real rheumatoid, that's okay. But rheumatoid treatment seems to help them.
Yeah, so if you apply that, then whatever their symptoms are, feel better, then you put it right.
Yeah, but am I going to put a lot of stuff into each joint?
Yeah.
Oh boy, no.
No.
I don't have that kind of patience to investigate each toe. If I straighten that one, or because not only there's each toe, there's which direction, blah blah blah. That is a specialty that it just is not mine. Beyond my capacity. Yeah.
Following on from that, what for specific? I've got a patient who comes for knees, an elderly lady, and I try to do the protocols and things. And how much of a local treatment, or what kind of local treatment would you do for her?
So, no, you can't. The only reason why you do the constitutional treatment is to affect the symptom, or to allow you to affect the symptom. So I want to make it really clear. We don't treat the symptom, because if you just treat the symptom, or we don't just treat the symptom. If you just treat the symptom, it will come back, because you never know what's holding the problem. Okay? So you can release the problem locally, and then the rest of the system is grabbing it again, because you haven't fixed the system. So I'm fixing the system as much as I can, so that then either then the knee automatically gets better, or if it doesn't, then I go for the local. But I don't do just the local, because the chances are, if I just do the knee, it will come back.
But what kind of local would you do?
Okay, so there's I don't do
Or
a
don't
lot
do
of
any
local is not my style. As much as I can, I stay away from the knee. But okay, so if you talk about what are the knee, what addresses knees. Your best thing for knees generally is stomach 41, spleen 5. Okay? If that doesn't work, if stomach 41 doesn't work, possibly stomach chi will work. If it's on the inner knee, gallbladder 26 tends to do a good job. If it's on the back of the knee, kidney 7 tends to do a good job. Inner knee, now there's also the Ita way of looking at it. So the inner knee eye belongs to spleen 4, possibly opposite side. Outer knee eye belongs to belongs to gallbladder 41.
You're right. Inner knee eye.
Hmm?
Inner knee eye.
Inner knee eye is spleen 4.
Thank you.
And liver 8 belongs to kidney 6. Now, if you're going to talk about now, any knee pain, kind of moving pain, undefined, is possibly liver 3 plus heart 5. Now, that was all very cute. Now, if you're looking at, Kawai does a more local treatment, and what he does, but that's a little bit more specific to, he does spleen 10 and stomach 34, needling upwards. Plus, possibly, I tend to add to that something along the stomach, like from stomach 31 to stomach 32, I'll find something. Okay. The reason he does spleen 10, stomach 34, it's like you're doing an uplift, facelift for the quad. Often, two things that are very prominent in knee pain: weak quads, tight tensa fascia lata.
Yeah.
Okay? Because if your iliotibial band, whatever that's called, is tight, it's so strong, it's going to pull on the knee, it's going to torque on the knee. Okay? So you've got to release that. Since it's very hard to release with needles, that's just the reality of it, that's where foam rollers come in really handy. So you have them on a foam roller, and and they roll. I mean, some people don't like doing it on the floor because you have to lift your weight up. Do you know what I'm talking about, foam rollers? Some people are going, no. Okay. Does anybody, do you have a foam? Because I have to show you, there's no way to, no foam rollers around here. Oh, bummer.
Okay, what about yoga mat?
Well, it's,
2 of these.
well, I'll show you sort of on this. Okay. So, because I can't roll on it, but, okay, and I don't have them do it on the table, but. Okay, so you want to release the tensa fascia lata. It's totally safe. They're basically on the foam roller. They're holding the leg is off the floor, and they're rolling up and down. They're walking on their hands. It hurts like hell the first time you do it. Okay? And you have. I had one woman. I had to say, okay, just one. Next day you do 2. It took her 4 weeks to get to 10. Okay, I mean, she just couldn't stand it. Okay, but most people, they can do 3 or 4. Ideally, you should be able to do 10, but with most people within 3 days, once you do it the first time and kind of like you get used to it, I mean, I can just get on and do it. So it's a non-issue for me. I mean, it isn't pleasant, but it's not a problem. Yeah.
Do you get people to do that on tight hamstrings as well?
Sorry?
Tight hamstrings, do you get people to do that?
Well, the problem with hamstring, see, when you're on your side, you have a lot of weight on.
Yeah.
Once you're on your hamstring, there's a lot less weight happening.
Yeah.
So it's not as easy
Not useful.
to do. Tight hamstring, hold on a second. Tight hamstring, UB20 is a good solution for that. I mean, I can't say that you do UB20 and suddenly they're like, oh yeah, I can then do it all the way through. But it's, now the other thing, no, but for people with tight hamstring, okay, everybody stand up. So what I want you to do is, I want you to like pick up pencils with your toes. Do this with your toes. Oh, wait, don't. Okay, you already did it. Never mind. Sit down. We'll do it in 2 minutes. Sorry, I should have had you check your hamstrings first and then see that it works. So, sorry.
Repeat what inner knee belongs to spleen 4 and outer knee belongs to...
Okay, inner knee is spleen 4, which you can combine with spleen pericardium 6, obviously, and outer knee eye is Sanja 5, which you can combine with. It's gallbladder 41, which you can combine with Sanja 5.
So that's on the extra order.
Yeah, and liver 8 pain belongs to kidney 6 category, which means you can add on 8 or 7, whatever you want. So this is just, this is the Ito ideology.
What about spleen 9, pain there?
Spleen 9 pain can belong to kidney 7, however, okay, so this is where Kiiko and I will differ. My understand, spleen 9 pain, it's usually a little behind spleen 9 or above. That is meniscus. That is a reflection from meniscus. Now you say that to Kiiko and she will go, absolutely not. She's adamant about it. Meniscus for her shows, she claims meniscus shows inner knee eye. My experience is I'm adamant that she's not correct. So I don't know. Now I will tell you this. I had a chiropractor friend who said to me, meniscus or ACL, how can you tell the difference? I don't know. I can't tell the difference. He says, yeah, neither can anybody else. But he's absolutely, the way he explained it was absolutely great. He said there are tests for both. So meniscus, for example, if you move the foot this way when they're lying down face up, and it hurts them, that's supposed to be meniscus. He said, but he's really correct because I remember I was a dancer. When I was a dancer, all the older people than me had meniscus surgeries. Okay? By the time I was out of the profession, and by the time I became an acupuncturist, no one ever heard of meniscus surgery. Everybody had ACLs. Never heard of an ACL before. Okay? About 10 years ago, we started having meniscuses again. So what he's saying, is it possible for that 15, 20 years, 20, 25 years, there's been no meniscus problems and suddenly they came back? No. It's just that we diagnose them both as if they're the same. We go and do the surgery, they scrape whatever they scrape, and nobody really cares about what it is. They just named it something, but it's kind of irrelevant. So once the orthoscopic surgeries came in, it was convenient for some reason to call them ACLs. I don't know why, but that seems to be the fashion. And I think that as they discovered that they're not all working, they said, oh, maybe it's meniscus then. That's my theory. But so spleen 9 to me is more likely to be meniscus.
And that,
And
you
that
tried
would,
kidney 7. You tried kidney 7 for that.
No, depending. I would actually try the spleen 5 stomach 41 first. And then then you can try the spleen 4 idea. And then remember that it's a tendon or it's a ligament, so maybe immune. So anything to do with knees, you may need to use immune points because immune and ligaments work together.
And what would you do? This particular lady has got she hasn't got any pressure pain apart from spleen 9, but she's got a really kind of, big lump here on the inner part of the inner part of the knee. So I think maybe this is the osteoarthritis, and she's got a big lump on both sides and on her shoulder here, on the clavicle.
Does she have pain in the clavicle?
No, she doesn't seem to have pain,
But pain in the knee?
anywhere apart from the kind of lower spleen channel.
No, but the complaint is knee problem.
But she comes for knee pain and shoulder pain.
Okay, so she has pain, okay. And there's the bumps.
She's got just on the
Look at
right.
gallbladder 26 as a possibility, T11, T12, because she has some sort of cross thing happening.
No, the knees are both sides.
I understand, but she has a cross thing between she has a lump,
She's got kind
and
of
she
the
has a
bone
pain in
is
the
kind
shoulder, so she has shoulder and knee, she has something that crosses.
But
I would look at gallbladder 26 and inguinal. as a possibility. I mean,
It's difficult with her. She's
well,
not
it's difficult with anyone that, no, I mean, it's difficult for me to be precise because I don't really know.
You can't see her, so. And the other thing is that she can't go face down, so a back treatment is.
On this, okay, people who won't go face down, that's not unusual. Side, on the side, treat them on the side.
And you have to do both sides?
No, not necessarily, no, you can do, I mean, it's more convenient if you flip, to do one side on the back as if you're doing Wattos, and then flip them to the other, but you can do this side and then needle the Wattos. It's less comfortable to do for me, not for them.
Right.
So, but no big deal. You can actually do the back treatment. It's less it's less comfortable, it's not as effective, in my opinion, to do back treatments on the side, but it's totally doable. Okay, so my suggestion is we need to leave here by 1:10 because we have a patient at 2 o'clock, so that's probably enough time to treat someone.
Can I ask just a question, please?
Yeah, you can ask a question.
There's something that's slightly worrying me. Moxa in liver 5.
Moxa on liver 5, yes.
You sort of implied that liver 5 really is a Moxa point.
I didn't imply, I explicitly said.
I think, all right. If the patient has heat in the liver channel, damp heat in the liver channel.
Okay.
I know, I'm sorry, I know it sounds a bit, how much heat are you putting into that channel through the threaded Moxa?
I don't know. I never thought to measure, I never thought it was worth checking out. I never thought that I shouldn't do Moxa because there's other heat in the channel. It's so not in my realm of thinking.
Yeah.
I want to tell you something. When Kiiko first came to the States, this is before I met her, so I've heard of it, and not from Kiiko. And so this is when the first acupuncture school in America was New England School of Acupuncture in Boston. She went there in 1979, and it was a one-year program at the time, and this is Ted Kapchak was teaching there. I mean, it was Dr. Su, it was a Chinese place, and she had basically just graduated from acupuncture school in Japan, and came and started living in Boston. And she was treating this child with throat infection by doing Moxa on kidney too. She would never do it now because it's just not in her style, but that was whatever she knew at the time. She's changed style since. And everybody was like, how can you do Moxa when this heat condition, blah, 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 it's the fire point, you're introducing more fire, and everybody was like, I don't know, whatever, the acupuncture world was very small at the time, so apparently rumors spread very fast, like fire. And by the time all the rumors spread and the Moxa was over, the little boy didn't have any throat pain. Okay. So there are ideas, and so the thing is, you have to understand this Moxa is not, the Moxa I'm using literally is not the same as the brown stuff you're using. Yeah. So it's a non-comparable thing. But I also want to suggest that in traditional Chinese medicine, there's a concept of fighting fire with fire also. Yeah. So I don't know what to suggest to you. For me, Moxa is not. If you're asking, if I said take a needle and put what we call kyutoshin on it, which is a blob of Moxa, and warm the needle up, warm it that way, I will say yes. Then but OQ is not about heat. No. OQ is about dissolving connective tissue. Okay, so it does not. You can't translate between the two. It's just. So if you're talking about taking a cigar or a Moxa box or any of those things that really heat, kyutoshin we're using, for example, on the abdomen or on the buttocks, where you touch inside and it's cold. You're trying to warm the inside. OQ is not about warming it up. Although we will use OQ when the feet are cold, you want to move the stimulation. When it's cold, the stimulation from the needle is not moving because of the contraction. So you're dissolving to make the needle stimulation stronger. Does that make sense?
Yeah.
Okay. Let's flip her over here. see 1, 2, 3, 4. Everything? Which one? The bottom, this one. Okay. And 1, 2, 3, 4. Everything? Ah, which one? 3 and 4. Okay. So on this side, she shows liver much more clearly, or she can say with the other. Okay. By the way, anything on UB43? No, just me pressing. You don't have to try and make it. With my pressure, is there anything?
There,
There, perhaps. Okay, and this one. We got that one. Okay, we understood. Okay. When I press down here, left side UB35. How's top UB43?
fine.
Okay. And I'm sorry about this. Okay, that's still jumping. Hold on. Is it better or not?
Better, yeah.
Okay, how much better? I know you're still jumping. I know it sucks, but
Can you do it again?
yeah.
Yes, a lot better.
Okay. Notice my UB35 is quite a bit wider than it is not Haftzun out. Okay, it's a good 1.5 Haftzun out. But I still call UB35. Now there's no distraction. Yeah. That reaction is very hard to get rid of. Okay. But just talking about pain. Hmm?
No, it's not painful.
Not painful, but still startling?
Yeah.
Okay. Hold on. And you had here and here?
Mm-hmm. Bottom one.
Bottom one, okay. Did you break your tailbone?
I'm not aware of it.
No.
I
It
did
just
fall off a horse once.
Sorry?
I fell off a horse, but
Okay, typical.
but on my face rather.
Oh.
Oh.
Oh, wait, on your... okay. How's now this guy?
Not better now.
Not better. Okay. Yeah, it's very hard to... It's very bony here. It's almost like a tailbone starts in the sacrum. There's not much flesh on top of the sacrum. So due to for the nervous system, even though we did not fix the left scapula. So UB35, due to. And now we're not going to see them anymore. Well. All right. So still something here, correct? Okay. In pretty much full force.
That was really painful just now. Down
This
there.
down here.
Yeah.
UB27. Oh, okay. I was going to do that. Okay.
No, further in, but you were further in first.
More here.
I don't know what's going now.
Okay.
It was definitely.
So just for a moment, how's this down here now? It's good. Okay. But maybe this is not so comfortable. Okay. Hold on. Any pain here?
No.
Okay, again, just because of possibly, she didn't say cardiac, but I'm just looking. The continuation on the back of, remember I talked about basilar artery insufficiency, which I didn't really do on her. Kidney 7 or 9, even though Nagano says kidney 10, plus liver 8, plus Sanjo 8. I only did the liver 8 out of the whole thing. The continuation of that is what we call ihikon. Okay? Ihikon is a combination that's basically UB60, 58, and sort of 40. The name ihikon basically comes from the names of the point. E comes from, you're Japanese, but you don't know the name points in Japanese. Weizong is the name of UB40. Apparently in Japanese it's called Izong. That's the E of the ihikon. Feiyang UB58 is apparently Hiyang in Japanese. And Kunlun UB60 apparently is still Kunlun in Japanese. I'm just surmising. So I want to see if you have discomfort here, right? Okay. 58. How's now?
It's still there.
No change at all.
Yeah, it's deeper.
So some change. Okay, hold on. 60 plus 58.
Pretty painful on the foot. But
Forget the
yeah,
foot.
Up there, yeah.
Up there.
It's okay, yeah.
It's okay. All right.
Why not just the bladder 60? 'Cause
Why
you-
not just bladder 60? She's not, if she was cardiac, because my reason for econ is more because, first of all, econ is for two things. Number one, head injury she had. Number two, meningitis, neck problems, meningitis. But number three, originally, this is a combination for things that started with fever. Okay. Are you okay?
Yeah.
Okay. Now, notice the UB40, it's not here, not the center one, even though it says UB40. Now we'll take, it used to be, do you see this triangle? On the lateral side of the triangle, we used to do this, and I still do. Kiiko will now basically do 39. I still do this triangle. So it's really about, you can call it maybe bladder 38 even. Okay. And I'm needling it towards the fossa.
Is that on all bladder 40s you would use? Or
No,
that
no,
particular
just this,
protocol?
that just for econ. Otherwise I don't use bladder 40s, I can't say actually. Hi, how's now?
Yeah.
Yeah, all right. Anything? Okay. Yeah, I get it. I'll try.
I try not to try.
No, don't try. You do what you do. I try, not you try. I try, it's my job. Okay, how's now? Let me take the hand away and come back again. Seems better, no?
Yeah.
Okay.
So you do 58 upwards as well, so again...
Slightly upwards. I mean, that's more because I'm not into needling straight in. It's not because I'm trying to do something with the angle.
But that's against the channel.
It is against the channel, yeah.
In her book, she does actually say, doesn't she, bladder 60 upwards, bladder
60.
58 upwards, bladder 40 downwards.
Oh, I don't know. If you say she says, I'll believe you. I didn't know that.
Apart from 6.
60 I know is upwards, and in my case 40 is cross. It is a cross, and 58 I'm doing upwards. I don't know. It's just I tend to see Kiiko doing it. It looks to me like she's doing it straight in, but I could be wrong.
And for econ, if you're testing against reflexes,
There's no clear reflex. Well, there could be one reflex which is under the occiput. I mean, you could test the neck,
which
but I
is
didn't test the neck.
if like two of them work and one of them doesn't really do anything, would you just use, say, if it's 40 and 60 work with 58?
I would tend to add, but I do manipulate this combination a little bit. For example, sometimes instead of UB60, I'll use GB39. So I would tend to do the whole. I told you, number of needles doesn't matter. This is still an idea. So for me, it's this all 6 needles. It's one thing. Even though I have 6 needles in. Okay. So. I told you that reaction is extremely hard to get rid of.
I had a massage client who used to do that when I reached a certain part,
Oh yeah.
and she went for a Bowen technique.
Bowen? Oh, she must have loved Bowen.
Relaxation, and that never came back after
Really?
relaxation with Bowen.
Wow. Interesting. I'm surprised because I thought that kind of person would never be able to tolerate Bowen
She found it
because they're
was, but-
twangy it. It's
Quite
interesting.
gentle, though.
Hmm?
It's quite gentle, though.
Bowen, yeah, the lifting the tissue and I mean the name Bowen comes from a name of a person, but it's just like bowing. It's just like twanging the thing. It's not very pleasant. Okay. Do you see? I didn't even. It's a skin reaction. It's a nervous system sensitivity. You see, that's okay. That's why I said I'll take my finger off and put it back in because it's okay. So now let's.
It's almost like ticklish, isn't it?
Yeah.
I have that really jumping.
Hmm?
I have that as well, really jumping. But
Yeah. No, that made it worse.
the mastery point there.
Yeah, but it was not gonna do it. So,
Which one's that?
I think it's small intestine 9-10.
Small intestine
9-10. It's a sympathetic dominance situation. Okay. So. Meaning that always, she's like ready to fight. I mean, you know, she's not consciously ready to fight. It's not like she's declaring war on me, but her body is like just ready to defend.
Escape the saber-toothed tiger. Escape the saber-toothed tiger.
Oh, I don't know the expression.
I'm interested in sort of the primitive reflex thing, you know, back from cave dwelling days.
Oh. I thought it has to do with dinosaurs.
Yeah, around that time.
Not that sound. No, there's sound.
No.
Better, huh? Okay, good. So now we'll add T5.
I'm interested in the emotional content of that.
Of this
Yeah.
or of this?
Of the nervousness, the jumping.
Well, we didn't investigate that much, but you know, we know that there's been in childhood abandonment and possibly other issues. We don't know what they are. And you can, but I've seen some people who don't have. You know, I mean, it's some sort of, now, they may not know, but you know, I mean, how do I know that she wasn't attacked as a child? And I don't know, I mean, you know, so it's possible that there's some memory, you know, body memory in there. So,
Can I ask what are those lower points, please?
Sorry?
The lower points that we see on the just above the
She'd
bottom.
like to see the legs.
No. The points are just above the bottom. What are they?
I would call that sacroiliac. So you can see I'm way wider than the sacrum. The sacrum ends here. And if I try to get a needle in here, it would be very hard for me. So I'm going across, on the other side of the ilium and getting the same ligaments.
So it's not bladder 27 then?
It's wider than bladder 27, but I would call it
You didn't say that.
sacroiliac, bladder 27, and UB53 to me are basically, sacroiliac is like a thing here, this way. It's a wide, so 53, 27, you know, 27 should be more in. Yeah, it's all pretty similar to me. And I tend to take them a little bit wider.
When you treat on the back, Avi, do you start with everybody trying testing the UB43 area, 1, 2, 3, 4? That's your first thing you do?
Unless, it all depends on how much of a diagnosis I already have. I might go 1, 2, 3, 4, the whole spine, but yeah, because almost everybody has that. And it's very important for me to calm down the nervous system. So if you ask, one of the things that I do on the back, just like, you know, I told you I have the Avi protocol for lifting. The Avi protocol for the back is basically due to possibly sacroiliac, T11, T12, T7, T5. It's as if everybody was under you know, hyperthyroid. I'm basically trying to activate the do. The back treatment is much more primitive. Now, yes, there are more variations on it, but if you ask me what does everybody get, this is pretty much what everybody gets. She didn't get T11, T12, that's all.
And so which ones are you? Sorry, which ones are you needled? The Quartos at what? T4, T3, T4?
T5, T4, T5, I would say.
Thank you.
I mean, it just goes with it. Is the arm okay? Because you're playing with your fingers. I'm not sure if your blood circulation is stuck here or... You're fine? Okay. All right. All right, let's take the next person.
Could you just repeat what your standard back was again?
Yeah, U2.
Yeah.
T11, T12, T7, T5. Basically just like hypothyroid treatment.
And then your original diagnosis is along the 43, the left.
Oh, the do2, yeah.
Up there, your left.
Because of autonomic nervous system issues. But, and then to that, if they were listed on the front, I'll add UB35 on the left. You know, I'll add to that, but that's kind of like the basic thing that in all likelihood all people will get is do2, activate the dude, take the highest point of the curve, so that's basically T11, T12, T75.
That's a standard back.
That's my standard.
A non-standard.
Yeah, well, except it isn't quite the seventh, it doesn't quite work that way. You know, I mean, if I wasn't, I mean, you know,
No, because that's L2.
because L2 would come to be a 7.
True, yeah,
I mean,
true.
it kind of sounds like
Minus
like
one.
that. Yeah, minus, yeah. 7 minus 1 plus 3 plus.
Avi, can I
Yes.
just something you mentioned yesterday and today? It's pertinent to me too.
Yeah.
And that was the link between immune and ligaments.
Yes.
Where does it come from?
Where it comes from is that they notice that people who've had that, well, find that stress attacks the ligaments.
Right.
So that's where it is. Okay? Okay, so we spoke a little bit at breakfast, so this is what I know you'll correct me.
Yeah.
Okay? So she didn't sleep last night, but she doesn't sleep most nights. Okay, what happens is she gets rumbling in her stomach and belching, and then she gets kind of like she can't disconnect from it. Her mind goes to that, and she can't sleep. It started 10 years ago with a lot of stress.
Yeah.
And
I have to kind of press in to release.
so you have to what?
Press in with my stomach.
She has to press the stomach to release, and then do you fall asleep or not?
To release
The gas.
The gas, basically. So there's a lot of forceful belching.
Where about one breast?
It can be, if the gastric can be under here, it can even be down here. And I just automatically seem to know where to go. It can go on for, on a good night, 3 hours, on a bad night, all night. I don't get any sleep.
And she can't sleep during the day. Okay, so she can't compensate for that.
The other thing I've noticed is I do pee a lot when I've got it badly as well, so I'm up to the toilet 4 or 5 times a week.
Okay,
Is
so
that because you can't sleep in George?
No, go ahead.
Is that because you can't sleep and therefore you think I'll go to the loo? Or
No,
because
I
you
just
think
feel
you'll
as
have
if my bladder is
Yeah, that's what I do when I can't sleep. I go to the loo. I can't sleep. Let's see if the toilet will make me sleep here. I mean, I could have a latte, or I could go to the loo.
Yeah, but if you don't go to the loo.
No, I know what you mean.
You know what I mean? You then think, oh, I'll be done.
But 5 times a day. I mean, no, once when you're already up and you sort of, I'll go pee. It's one thing. But it's like if you're up 5 times, it's all like, I'll go pee and see if I go back to sleep. That's like a little, that doesn't make sense to me, but maybe everybody's different. But, so it's always good to ask because you never know. It's like, it wouldn't occur to me to. All right, let's.
The Dogen, is it always just, like, would you ever, is it related to eating? Like to food?
It doesn't appear to be, because if I don't eat, I can still get it. And I have changed my diet drastically. Because I was told it was a bacterial overgrowth in my small intestine. And
But only ever in the evening? Like,
I don't get it during the day.
So the tide last night might not.
It wasn't, I didn't, it was a tiny bit, so it wasn't good to me.
So, yeah, but apparently it's not related to foods because she cannot eat in the afternoon and she still has it. So, now, one of the things, I'm thinking it's autonomic nervous system besides the fact that she says it's stress. The other thing is there's a switch, there's not exactly a switch between day and night, but there's something like, I mean, it's good that you don't sleep during the day, but if she can't sleep at night and she can't, she can't compensate for it during the day. Now, it's not related to lying down. We've established that also, that it's clearly the night. So anything that has to do with day-night is either autonomic nervous system or the other option is stomach chi. She has some lumps here.
can you say?
Because stomach, earth, is the thing that allows you to make shift. So, does that make sense? Okay, so those are options. Now, when you're looking at her, Do you see there's a big depression here? Okay, I think that's probably part of what's going on. You know, regardless of pressure being. Why? So if she were going to have pancreatitis tummy, it will be here, a little bit maybe below. Okay, so let's just. Now you had appendix and what else?
Appendix age 12.
Oh, you said adenoids removed.
Adenoids
and
are
tonsil.
much younger, age
Okay.
7. Current tonsillitis is teenager, and glandular fever.
Can you get her neck on the thing? No, don't do anything special. Do you see she's, well, now she's changed it, so just, do you see she's puffy here? Especially on the right side. Can you see? There's a puffiness here.
Which one? Sorry.
In front of the sternocleidomastoid muscle.
Yeah, in front and over it. It's a little hard to see now. Don't lift your chin. Do not lift. Yeah. Okay. Do you see it now? This is puffy. All right.
So you were looking for.
I'm just looking at this point.
Okay.
I
Was
haven't
that
touched.
observation or was that just?
It was observation.
I know, but did you know it was going? Did you suspect it was going to be there?
No. I just watched it, and you know, it is what it is. All right. So I'm just
Insomnia.
my hand, right?
Okay.
Anything here? She has a red 9 pulse because I can feel it already here.
Yeah.
There's something here?
Yeah.
There is. Okay, so how about this side? That feels like gassy to me. It does to you
It's
also.
tender.
How about adrenal?
Not so much.
Okay, other side?
I can feel the pulse.
Yeah, so can I. But you know, and now we feel the pulse officially. How about red 12? And I can still feel the
I
pulse.
can feel the pulse moving up
Okay.
to here.
Okay. How about stomach 21?
It's a little bit
A little bit?
hard.
Okay, hard. How about this side?
It feels okay.
Okay. So hard here. Okay. So oketsu, other side, lots of pulsing, and stomach 21. How's red 17?
Slightly sharp.
Slightly sharp. Okay. How's 15?
That's okay, actually.
And she has rapid pulse. I didn't even take because I could feel it already in the abdomen. So.
It can be very slow though. That's
Oh yeah, you said something
Yeah.
about that. Oh, she said that when she gets, she's normally a slow pulse, but when you get this, you know, the pulse races. That's another autonomic nervous system indication that the pulse changes rate so readily. You know, so okay. 1, 2, 3. 3. Okay, 1, 2, 3. Okay, just this one. Okay. How about liver? Spleen, liver. This is liver's tender. How about 14? No change. But this is tender.
yeah.
Okay. Any pain on liver too?
No.
Spleen too? Kidney too?
A little bit, yeah.
Okay. Kidney too?
Not so much in that sense.
Spleen too?
It's okay.
Liver too?
A little bit.
A little bit.
Yeah.
Okay. Liver to a little bit and kidney to go. Okay. Talking about this one. How is now? The liver.
Easier.
By how much?
30%.
How much?
30.
30? Okay, forget 30. How's now?
No, it's not as good.
No, it's good. Okay, I told this was Kiiko's liver one. It's gonna work for Kiiko, but it's not gonna work for me. What can I say? It's okay. That's individual variations. How about now?
It's not, it's probably about 40% maybe.
Whereas this one was 30%?
Yeah.
Okay, so the middle of the, not the middle of the toe, but the you know, Jingwell, like real Jingwell, as defined by the book. As defined by the book. Okay. All right. You said here, right? Oh, you had kidney too. Okay. How's now?
I don't actually feel it now.
Okay, good. How's the liver?
It's better.
By how much?
Another 20%.
Meaning 60 altogether?
Right.
Okay. You also have to know how to do math when you treat people. Okay. How's this going?
I can't remember what it's like before.
Oh, okay. Hold on. I'll remind you. Here.
Okay.
And with kidney 7.
Not much change.
Not much change. Okay. With kidney 9.
It's more pain.
More pain.
Well, actually, no. It's painful in my legs.
Okay, forget the pimple in the leg. How is the belly?
It's still...
No change. Okay. And also no change with kidney. Okay, hold on. Kidney 7. Okay, that's okay. Because she has appendix. By the way, any pain on the scar?
Slightly.
This one. Okay. Because this is not, they wanted to do a nice job so we close the bone. This is not appendix reflex, this is just the scar. But because it was done for appendix, chances are spleen 9 will do it, and then I'm hoping that we'll do the stomach 26, 27. Sorry about spleen 9. How is the scar?
It's fine.
Fine. And how is it, this guy?
That's not tender.
That's not tender.
Slightly harder.
Slightly hard, but not, okay, no, that's fine. And you have here too, right?
That's fine.
That's fine?
Mhm.
Okay. Okay, what else did you? Oh, stomach 21 this side. Hard, right?
Mhm.
How's now?
Slight change, maybe 20%.
20% change. Okay, that's okay. Stomach 21 can respond to opposite side.
Quite the same.
Okay, forget what I said. It was a nice thing to say, but it didn't work on her, so it's not relevant. Okay, we'll figure that out. Let's get you started.
Can you sort of just maybe summarize that first of all?
Yeah, what you're thinking.
What am I thinking? Okay, I'm not, okay, first injury, what I want to do is I want to do spleen 9 and immune, and then treat the nervous system. You know, because she had appendix and she had the adenoids, etc. Then I want to see what the effect is, and then I want to treat the autonomic nervous system. Does that make sense? Plus, do you see how puffy this is? I mean, there's more puffy, but that's an indication of something's weird in spleen 9. But hold on one second. Any pain when I do this? No. Okay. I'm checking if the spleen channel has bumps, but it's not a huge deal.
If it did, would you need it like stomach channel?
No, then I'm interested in tie-in joint.
You're interested? Oh, yeah.
In the joint points. So it was just, I don't want to get into it unless we have to, so we don't have to, so it's okay.
So a puffy spleen 9 would indicate...
It's one of the indications for a spleen 9 type, or it's a spleen type. In her case, she's spleen 9 because of the appendix. 1, 2, 3. And how's that?
About 30%, is it?
Okay. Now,
Maybe another 10%.
only 10%. Hold on one second. Can you press under the third toe on the right side? Right, yeah, that right. How's now? Lots better. Okay. Can you press under third toe both sides?
Are you checking that against Sandra 16?
Yeah. Yeah. But the thing is, she get X amount better, and then she said a little bit better. So it's like, okay, I don't have a choice. I do have to treat the autonomic nervous system first. Okay. Hi. How are we doing here?
Slightly tender.
Slightly tender. And here?
Spinal.
Try and get you your nail in here. You were a little bit here.
This side of it.
Yeah. Under third toe does same side until it hits the rib cage and then it crosses over. Its effect. So, high. Better?
No.
No. Okay. It's not your fault. How is now?
That's better.
That's better. Okay. So you see, sometimes you need a combination. How much is left now?
10%.
10% on volume.
And what point was that which would made it better?
Sorry? A combination of under third toe and immune. So the thing is, she's autonomic nervous system, immune, and appendix, which is still an immune category in a sense, but it's especially because it's really a digestive organ. It's still a benign.
Okay.
And if you were working on your own, how would you manage that?
You just do one at a time. Yeah, it's like, or what you can do is you stick a magnet on and check, but no, I just do one, I do one at a time, but I can do it a lot faster on my own because I'm not, when I'm teaching it, so it's all a lot slower.
If you put magnets on to do that, would it be
Oh, just for a
north,
second.
south, pole, sort of?
Oh, north facing.
North.
No, north facing, but the thing is, it's just for a second, it's not, the treatment is not with magnet.
No.
It's just for a moment to, instead of my pressure, then I do with the needle. For the patient to take home, north facing the skin, if it's just 2 points, like under the third toe, but actually it's always best to have north and south. So main point is going to be north, secondary point will be south, unless it's on the same channel, in which case you're going with a flow of the meridian from north to south. Does that make sense for everyone? Here? Now?
So, 80% better.
80%. Okay. How are we doing now?
Just tiny bit left.
Tiny bit left, okay. And here?
That's fine.
That's fine, good. All right. We can't forget Mushu because she has a Ren9 pulse. And so I've sort of started addressing the nervous system with under the third toe. Okay. You feel the pulse, right? Yeah, I know you can still feel it. The pulse very rarely disappears, especially hers is really, really strong. Do you feel less or not?
No.
No, yeah, it's okay. It's okay. Hers is really, there's a tightness to it, but actually...
Could we palpate that around close?
Come. Can you do me better? Yes. Come on. Put your hand on. Don't push in. And don't push your hand in. Come, push from, yes, thank you. Does it feel easier on you? On the two different ways you palpate? You are like, you are standing there and palpating. So just move in a little bit more. Go ahead.
Is that the same pressure as well? Is it?
Hold on. The depth is not important.
Sorry.
No, I'm serious.
I don't mean to feel across, but when you're palpating in general, is it important to get similar to what you're doing?
No,
To get the
it actually
reflex?
isn't. And it's kind of strange how, in classes where people insist on people will give feedback. No, usually people say that the student's pressure is much stronger. So people are kind of always surprised that it's actually not, that I'm not quite as, it looks like I'm, and it's actually a lot less than one thinks.
When watching, I thought you were using much more.
And that now you're feeling it, you're going, oh, well, that's not a big deal. Yeah. All right. So, we have one more to complete with it. I'll give you a bit. Now we could go. Okay, we'll check them all. Okay. So stomach 21 right now is okay? No, still so. So number 1. How's 21? A bit easier.
What was that with bladder?
With bladder 2, I prefer, if I could get away with bladder 2, I will. The reason why is because bladder 2 also releases the diaphragm, remember? So for her epigastric pain, it seems like bladder 2 will be a better combination, but I just want to check.